Just give it a moment for everybody to join in and see how many participants we get, and then we'll get started. All right. Hello, everyone. If people flood in, that's totally fine, but I'm going to go ahead and get started with the interest of time. So my name is Brianna Montgomery, and I would like to welcome you to the Autism Intervention Research Network on Physical Health, the ARP May webinar. Thank you all for joining us. Because of the number of participants, your audio will be muted throughout the call. However, you can submit questions at any point during the presentation via the Q&A feature or in the chat box on your webinar console. Just a friendly reminder to please be respectful when communicating in the chat and asking questions. Only questions or comments pertaining to the presentation will be addressed. The entire webinar is being recorded and will be available on the ARP website, airpnetwork.ucla.edu. You can also place that in the chat when I get the moment. You may also view the presenter slides to follow along on our Google Drive archive. I will place that in the chat momentarily as well. There will be a short evaluation survey at the close of the webinar. We invite you to provide feedback on this webinar and also to provide suggestions for future webinars. In the interest of time, let's get started. We first want to acknowledge the Health Resources and Services Administration as the funding source for the ARRP. In the interest of time, let's get started. Oh, sorry, just said that. It is my honor to introduce our presenter for today, Dr. Kristen Choi. Dr. Choi is an assistant professor at the UCLA School of Nursing and a co-leader for the ARP Primary Care Services and Quality Node. Please join me in welcoming Dr. Choi.
Thank you so much for that introduction. Good afternoon, everyone, and I want to thank you for coming to the ARP webinar today. I'm going to be presenting some research that I have been working on in the past couple of years on teletherapy for autism during the pandemic and how parents really felt about this modality for doing therapy for their autistic children. Just a bit of context on this project. I'll actually go to the next slide to acknowledge my funding here. So of course, the ARP is supported by HRSA, and the research that I'm going to talk about today is supported by the Agency for Healthcare Research and Quality. Prior to COVID, before we all were living in a COVID world, I was working with a grant from ARC on some research with Kaiser Permanente, Southern California, looking at therapy and other healthcare services for autistic children. At the time, Kaiser had really increased the amount of therapy of many kinds that they were providing to autistic kids. And my project was really designed to explore that, to look at the extent to which kids and their families were benefiting from these services. And we had a particular focus on evaluating applied behavior analysis and the extent to which it really improved the lives of children and their families. While we were doing that project, COVID happened, and so I had the opportunity to obtain some supplemental funding from ARC to add some COVID-related aims to the study. And so because we were focusing on therapy, we decided to take a look at teletherapy and really explore how that was working for families and if it was working at all, as well as to look at mental health among the patient population there at Kaiser. So this presentation is going to be focused primarily on the COVID-related aims from that study, although at the end, if there are other questions about our parent project, I'm happy to touch on that as well. So again, I'm an assistant professor here at UCLA. I also am a registered nurse, and I practice in inpatient child and adolescent psychiatry, working primarily with kids who are experiencing psychiatric emergencies. So for some background to this study, we know that there have been significant challenges to families of autistic children during COVID. Certainly, probably the biggest disruption had to do with school closures. We know that a lot of families had disruptions to their usual routines and services that their children might have been receiving, especially if they were happening from school. We also know that there were a lot of economic stressors for families that really affected parents and families as a whole during the pandemic. I didn't put this one up here at the time I made the slides, but I just heard this week that we have unfortunately gotten to the close to 1 million mark of deaths from COVID during the pandemic. And I think another one that we have to be really thoughtful about is grief and loss in the lives of children when we think about how many people that we've lost in this pandemic. Research on COVID itself has demonstrated that there is elevated risk for serious COVID-19 illness as well as mortality for individuals with intellectual or developmental disabilities. And we also know that during the pandemic, there has been elevated risk for parent and caregiver stress, as well as mental health concerns, again, probably because of the confluence of all these factors coming together. So during COVID, of course, we had a very rapid shift to telehealth for a lot of healthcare that happened during 2020. And that was certainly true for health services related to autism that were being provided by health systems. In our context at Kaiser Permanente, a lot of the behavioral health services like speech therapy, occupational therapy, and applied behavior analysis shifted to an online telehealth format during COVID-19. I see a typo there. It says COVID-18, that should be 19. And there was really a proliferation of telehealth for psychiatry and behavioral health across the board during COVID. And, as we've sort of moved out of the most acute phase of the pandemic, I still am seeing a lot of enthusiasm for telehealth models of care. And that's especially true for behavioral health because a lot of the services provided are non-procedural. There's a lot of enthusiasm for retaining telehealth as a way to increase access and ease of care. A lot of people like it and think it's a really promising modality. However, we don't know a lot about how patients and families actually feel about this modality in every context. And there really isn't a lot of research for families who have an autistic child about how they might have experienced telehealth, what they thought of it, and whether it worked well for providing the services they may have been receiving in person pre-pandemic. So that is really what our study sought to explore. The purpose of the study was to investigate whether service losses during COVID were associated with worsened parent mental health or child behavioral health. And when I talk about service losses, we explored loss or delay of a variety of different health, therapy, mental health services, as well as the loss of childcare. And then our second aim was to identify factors associated with favorable appraisals of telehealth, trying to identify who might be able to benefit from this modality going forward. So those were our primary aims, but around the time we were doing this survey, we had a couple of opportunities to embed some secondary research questions in the study. So one was around survey recruitment. At Kaiser, there have been a number of surveys of parents of autistic children that have happened in the past. And there have been problems and challenges with having appropriate representation of all demographic groups in those surveys and some mixed feelings about methods of survey recruitment. And so we really wanted to identify whether there is a certain method of survey recruitment that might be effective for engaging parents of autistic children in research. And so in our survey outreach, which I'll talk about in a few slides, we actually embedded a small randomization where we randomized each parent to receive follow-up via phone, text, or email. Phone and email follow-up are fairly common in surveys, but text follow-up is newer and not used a lot. And so we wanted to really focus on that one and see if using text messages for follow-up might be an effective way to engage families in research. Secondly, around the time that we did this survey, this was back in the spring and summer of 2021, COVID vaccines were not yet approved for children under the age of 12, but we suspected that approval would be coming in the fall or winter of 2021, which is what happened. And so in this period pre-vaccine approval for younger children, we also wanted to explore COVID-19 vaccine intentions and whether parents had higher than average levels of vaccine hesitancy and how that affected their intentions for their autistic child to be vaccinated if a vaccine were to be approved. So this study was a web-based survey of parents. Parents were the main group that we targeted to respond to the survey, and it took place at Kaiser, which is an integrated health system here in Southern California. Kaiser is a very large system. It covers 7 counties here in Southern California, and they have more than 4 million members. And so from their patient registry of autistic children, we know that they have had over 70,000 individuals who had intellectual or just developmental disabilities, as well as autism during the study period. So this survey took place during the spring and summer of 2021. And to get a sample for this study, we randomly selected 2,000 children from that autism patient registry. And we selected children specifically who had had at least one autism-related therapy referral in 2020. We wanted to try to capture folks who were actively engaged in therapy so that they were likely to have had their services shift to telehealth during COVID, which is the reason for that particular inclusion criteria. So for our survey, we first, we linked children to their parents, which is possible because Kaiser is an HMO and typically whole families will be Kaiser members. And we first sent parents a mailed letter as well as an email notifying them about the survey opportunity and providing a link to participate. Then we randomized parents to one of 3 follow-up groups. So all of them got the same number of follow-ups 2 times, but it was done via phone, text, or email, depending on which group that they were randomized to. The survey was offered on RedCap, and we offered parents a $30 check as a small thank you for their time spent completing the survey. So of the 2,000 children that we first selected, we found that about 1,600 of them met our inclusion and eligibility criteria. And in the end, after all of our recruitment attempts, we got about a 20% response rate and had 322 parents respond to the survey. That was a bit lower than what I had hoped. We had hoped that with all of our recruitment attempts and the incentives, we might be able to get that a bit higher. But I've talked to a number of folks who do survey research, and I think the consensus is that survey research was very challenging during COVID, and that a lot of people doing survey research saw a lower than usual response rate. So 20% is okay. It's not as high as I would have wanted, but in the end, we had 322 parents in our sample. We compared the parents and their children who responded versus those who didn't respond to see if there were any differences. And they were about the same on just about all of our demographic variables except for gender. We found that there was overrepresentation of autistic boys. About 85% of respondents had an autistic boy. And in the Kaiser population, generally, that number is more like 78%. So slight overrepresentation of boys. But other than that, those who responded versus did not respond were fairly comparable. So next, I'll talk about our survey measures. We had 2 outcomes, one for each aim. So the first set of outcomes was parent mental health and child behavioral health. This was a pretty simple survey item that we developed, and the question basically asked, since the pandemic started, has your child's behavioral health gotten better, worse, or stayed the same? And then for parents, has your own mental health gotten better, worse, or stayed the same? We also developed a telehealth appraisal measure. We have an occupational therapist on our research team who helped us put this together. That had 7 items assessing different dimensions of telehealth from the perspective of parents of autistic children. And this was a measure that we developed specifically for the study. It used 5-point Likert scales, and I believe the measure had about 35 points total score, with higher scores meaning a more favorable appraisal of telehealth. So for our exposure variables, we were looking at a couple of things. So one was COVID-related service losses. We really wanted to understand whether delayed or missed care played a role in affecting parents' mental health or child behavioral health, as well as how people thought about telehealth. And we looked at both healthcare as well as childcare, because we know that childcare and caregiving was a substantial challenge for a lot of families during the pandemic. So for our healthcare variable, we looked at delayed or missed care for well child visits, sick child visits, as well as other procedural and specialty care, as well as therapy and mental health. And then we also asked families about loss of regular childcare. We also considered COVID history. We assessed whether parents or their autistic child had a history of COVID-19. And then also we assessed parent COVID-related stress. There is a newer measure called the COVID stress scales that came out relatively early in 2020 that assesses 6 different dimensions of COVID-related stress. And so we assessed for that as well in our survey. Besides these main outcome and exposure variables, we also measured some other demographic variables and other things that we thought might affect that relationship between our exposures and outcomes. And so we considered demographics. We looked at age, gender, race, insurance type, whether the family had more than one autistic child, as well as parent, marital, or partner status and employment. We also considered pre-existing parent depression, as well as a measure of child autistic traits to try to adjust for as much as we could the baseline status of where parents and their kids were coming from. And then we also included a measure of caregiving strain, specifically related to parenting an autistic child. Right before our survey launched, we added some late-breaking items on parent COVID vaccination status, intentions for child vaccination, as well as vaccine hesitancy. So for our analysis for this study, first, we used bivariate tests to compare survey responders versus non-responders. I already mentioned this, but we did have higher response from parents of boys. And then we use multiple linear and logistic regression models to look at associations between our exposures and outcomes, adjusted for all of the covariates that I just mentioned. So this first slide shows just a description of our sample, so we know who we're talking about when we look at the results. So I already mentioned the piece about boys. About 3/4 of the children were under the age of 12. We had a much smaller group of teens in this study. And when we looked at the race and ethnicity breakdown for this sample, the largest group that we had represented was parents who identified their child's race as Hispanic, which made sense to us. That's largely the biggest demographic that we have here in Southern California. And so we did see that show up in our survey. We also found that about 1/4 of the parents who responded had multiple autistic children. And then in terms of COVID history, that was relatively rare at the time we did our survey. Those numbers might be different now, but at the time we did the survey, it was about 15% of parents who had tested positive for COVID-19 and about 6% of children. And so this first graph shows just the frequency of service losses, which was one of our main exposure variables. On the healthcare side, the different healthcare services are sort of stacked in order of frequency. We found it was most frequent that families were reporting missed well child visits or vaccinations, sick or chronic care visits, as well as mental health and therapy. There were some families that reported missed specialty care, surgery, procedures, and other kinds of things, but by far the most common were those basic well child visits and sick care. We also found that more than half of families, about 55%, reported loss of regular childcare. So that was a big issue in this particular sample. So we also included in our survey, we asked all parents if they had received some sort of therapy for their autistic child on telehealth. And if they said yes, we asked them to rate sort of on a general item whether that therapy was better, worse, or the same compared with in-person services. And so for the 4 types of therapy we assessed, we look at applied behavior analysis, speech therapy, occupational therapy, and psychotherapy. As you can see, by and large, parents really rated telehealth worse compared to in-person. Maybe for psychotherapy, I think that one was probably closest to being rated as about the same, but by and large, parents who tried this modality seemed to not really like it, and occupational therapy especially was the one that really seemed to have the lowest ratings and the most parents who felt that it was a worse format compared with in-person. So in our model, addressing our first research question, so was there an association between service losses and parent mental health or child behavioral health? What we found was that healthcare-related losses were not associated with either of these outcomes, but we found that several caregiving factors were. In our models, having loss of regular childcare was associated with nearly 3 times higher odds of parents reporting worse mental health during the pandemic. We also found that for parents who had higher caregiving strain scores related to care of their autistic child, that was associated with worsened child behavioral health during the pandemic. Our second research question was to look at telehealth appraisals and whether some of these same factors had any association to telehealth. And what we found here was that caregiving strain scores, that's what's labeled in the table as CGSQ scores, people who had higher levels of caregiving strain were more likely to dislike telehealth and not perceive it quite as favorably. And then interestingly, we found that parents who had more COVID-related stress had more favorable appraisals of telehealth and tended to like it a little bit more. I didn't show all of the demographic covariates in this table just for the sake of space, but I also do want to highlight that for parents who had a teenager who they were reporting on in the survey, those parents were more likely to perceive telehealth favorably. And then also for families that had multiple autistic children, having multiple autistic children was also associated with liking telehealth a bit more. So some discussion points about these findings. I think when we started this study, I'm a nurse and a healthcare provider, and we thought that loss of healthcare would be something that could be serious and detrimental to these families. But really what we found that it was the caregiving factors that were associated with worsened parent mental health and child behavioral health during the pandemic. Loss of regular childcare as well as caregiving strain were really the only significant variables in our models. And so it's really those caregiving factors that seem to play the biggest role there, and not so much the healthcare services or the therapy or other kinds of things. We know from the literature that as many as 60% of families with an autistic child report unmet childcare needs, and also that in this population, childcare can be a major source of stress. Parents say regularly that it affects major decisions like employment and can be a significant stressor. And so those things certainly held true in what we saw from this study. We also found that telehealth was really not preferred by most families who tried it. For those families who had higher COVID-related stress, they found telehealth to be more favorable, which makes sense. I think if you have more concerns and fears about the pandemic, then being able to do care from home might be something that you really like. But in general, most families appraised telehealth as a modality as much worse compared to what they had experienced in person. And so, I think the real takeaway from these findings is that as we think about the future and how telehealth fits into our healthcare systems, it's important for us to think carefully about which aspects of autism-related healthcare can be successfully delivered via telehealth and who can benefit from this modality, but also retaining in-person models of care for families that might prefer that. Again, I think there's a lot of momentum around telehealth. I'm someone that likes technology and is very supportive of that. But I've had some concerns about sort of going all in on telehealth before we're really sure that it makes sense for people. If you think about it, to be able to use telehealth, especially for behavioral health or therapy or anything related to mental health, it requires a lot of resources. You have to have the devices, the internet bandwidth. You have to have time and privacy, uninterrupted space and time. And some of those things are not something that we can necessarily assume that everybody has and everybody wants to use when it comes to getting these kinds of health services. I think that telehealth also has been talked about quite a lot as something that has a lot of potential to ease gaps in unmet mental health care needs and behavioral health care needs. And that's very possible. But I think a lot of the telehealth models I've seen are creating more options for care for people that perhaps already had access, but maybe not making so much progress in terms of reaching people that may not have had good access to mental health care at all pre-pandemic. And so I think those are some factors that we just have to think about when it comes to retaining these models and thinking about how they fit into our healthcare systems. So a few other discussion points on our study methods. So the strengths of the study were that we were able to recruit a racially diverse sample. We measured multiple pandemic-related variables that don't have a strong evidence base yet. And we also randomly selected a sample, which was pretty close to representative of our patient population besides gender. Limitations of the study were that we did have underrepresentation of girls in this study. There's certainly a possibility that there could have been reporting bias from parents. It's possible that parents that either really disliked or really liked telehealth might have been more motivated to respond. And also, depending on the kinds of experiences that parents had with therapy pre-pandemic, that also might have influenced how they responded to this survey. Finally, the survey was really focused on healthcare, and so we didn't have detailed measures of school-based services. However, we know that it's very common that families might obtain services from schools, from regional centers, other community organizations. And so it's possible that we only captured what was provided by the health system, and there might be other services out there that we just weren't able to measure. So as we're getting close to the Q&A period here, I want to also just briefly touch on the findings from our secondary research questions around randomized survey recruitment, as well as COVID vaccines. So as I mentioned, we built in some randomization into our survey recruitment and randomized families to phone, text message, or email, and wanted to know which one worked the best. What we found was that they were all equally effective. There wasn't any one method that worked better than the others for eliciting a survey response. And we did find that parents of girls in general were less likely to respond to survey outreach attempts of any kind. Again, there wasn't any one that seemed to be more effective at reaching parents of autistic girls. And so the takeaway to this for me is that I think, especially around text messaging, which isn't used as frequently, I think these findings demonstrate that it might be possible to incorporate digital or mobile approaches to survey recruitment, and that can be an effective tool for recruiting parents of autistic children in research. When I think back on conducting this study and doing a lot of the recruitment myself, it can be quite time and resource intensive to make phone calls to thousands of people for survey follow-up. And so being able to know that text message and email can also work quite well is really useful and helpful for us in thinking about future research with this population. Secondly, we looked at parent COVID-19 vaccine intentions. And again, the context for this was that COVID vaccines were not widely available for children at that time, only for children who were over the age of 12. What we found was that about 35% of parents intended to vaccinate their child against COVID-19. And we also found that this particular sample had elevated levels of belief in vaccine harm compared with national averages. That makes sense. We know that sometimes among parents of autistic children, there is a history of some erroneous vaccine-related beliefs. And so we did see that that was an issue to some extent for our sample. In our models where we looked at predictors of intention to vaccinate, what we found was that having positive vaccine beliefs was associated with intent to vaccinate, but a belief in vaccine harm, provider trust, and parent vaccination status were not significant predictors. That healthcare provider one, I think, was the most interesting to me. There is a lot of discussion and dialogue in the healthcare world about the importance of the role of doctors and nurses and pediatricians in encouraging patients and families to be vaccinated against COVID, and really trying to leverage the trust that we know that people have in their pediatricians and healthcare providers. But I think for some people, especially those who might hold misbeliefs about vaccines, it's not always going to work to rely on that provider trust alone. And for some families, we may need to be a bit more direct about addressing their vaccine-related questions or beliefs and really targeting those things more directly versus just making a recommendation and assuming that people will take it. So in conclusion, from our main study, what we found was that caregiving factors play a significant role in parent and child well-being during the pandemic. And, you know, our study didn't directly measure this, but I think the implications of what we found around caregiving was that it's really important that we support families with caregiving resources. And so some policy interventions that are being discussed, things like paid family leave, high quality childcare, really might have outsized benefits to families with autistic children. We also found that telehealth appraisals were not very favorable overall for this population. And so I think telehealth is still a very promising service delivery modality for us to explore, but it may not be able to fully replace in-person services. And we have to be really individualized about who uses that modality and making sure that it's actually accessible for people. Third, we found that mobile and digital recruitment strategies were effective for engaging parents of autistic children in a survey, although there are still some ongoing challenges in terms of recruiting parents of autistic girls. And finally, related to the COVID vaccine findings, it's important for clinicians to assess and address parent COVID vaccine beliefs and concerns, and not just rely on trust alone as a reason why people might take our advice as healthcare providers. So thank you very much for your attention. I wanted to share my email address here if anyone has any questions, and also the full article reporting results from this survey should be coming out any day now in the Journal of Developmental and Behavioral Pediatrics, and I put our authorship team here as well. I'd be happy to take any questions or comments about the results presented today. Thank you.
Thank you so much, Dr. Choi, for that presentation. That was great. We do have some time for questions, and from the audience. But as we give the attendees a chance to think about those, I want to invite everybody to attend and register our next webinar. I'll place that link in the chat as well. Okay, so I see one question, in the chat. It says, while the study concluded that the issues were more caregiving related, how much do you think the professionals' ability to deliver the services impact families' attitudes and the study results? After all, the pandemic caught us all by surprise, and training for professionals to deliver telehealth was not available, at least not at the beginning of 2020.
Sure, absolutely. That's an excellent point. I think that there could have definitely been health system or provider factors that affected how families perceive telehealth. And I absolutely agree. I think at the beginning of COVID, it was a really rapid and abrupt jump to telehealth, and it was probably rocky in a lot of cases. So certainly there could be provider and health system factors as well. And I think that'd be a great thing to try to measure in future studies. This particular study, we didn't survey the providers, it was just parents. But I totally agree that could be a factor and would be great to look at. Any other questions or comments from the group?
See one other here. It says, do you think there was any significance to the difference in boys/girls parents who responded?
Yeah, I think so. So I think it's fairly well documented that engagement of parents of autistic girls in research is a challenge. They are underrepresented in a lot of studies. And because autism is more prevalent in boys, I think that it's often something that parents of autistic boys are, this has been my experience as a clinician, often very motivated it's identified early, and they're more motivated to get them into treatment. I think for girls, there just can be a difference of how parents see autism, and that may have affected their willingness and interest in participating in research. I think in the future, we would want to do much more specific outreach to that group, as well as oversample for girls to try to get a more representative sample and make sure that those perspectives are included.
I kind of have a question. So as we move forward with this pandemic 2 years later and telehealth, do you see it more of like an increase for the use of it, a decline in it, the use of it, and how does it affect the families and their access to telehealth?
In terms of like using telehealth?
And using telehealth and like the pandemic and just
Yeah. So I think that largely a lot of people have gone back to in-person care for many kinds of care. And I know at Kaiser, a lot of the services have gone back to being in person. That being said, though, I think like I said, there is still a lot of enthusiasm for telehealth and wanting to try to sort of keep that and embed that in the behavioral health space. Like I said, I think the real key is that the modalities that we offer to people is something that's going to be very individualized for families. And I think that some families are probably comfortable now going in person, and that's fine for them. And there may be others that are not comfortable, who might have more COVID-related stress. And certainly that can change as the pandemic changes and if we see future waves of infection. So, I hope that other health systems will offer both and really just give families options for which modality is right for them, because it's going to be different for everybody. And I think we can reach the most people if we do give them that choice.
I agree. Yeah, I previously worked in a different healthcare setting, and there was always concerns about the accessibility of using telehealth, and having a hybrid model definitely helps both.
Absolutely. Yeah.
So, thank you.
Mhm.
Any other comments, questions? Dr. Choi, we've done a great job with this area of work, and very excited to see moving forward where this goes. So nobody has any other comments, questions, or concerns. I will also put the survey in the chat, so that way you guys can give some feedback in response to this webinar, and any advice for future webinars, that would be greatly appreciated.
Awesome. Thanks everyone for attending.
Thank you. Have a great day, everybody.
Bye.